Your name and any organization you are representing for the record.
My name is Mitch Leffler. The Make Duchenne History Coalition arranged my travel here today. And I have a 12-year-old son who's been on Dresipearson and is now on eteplirsen. The decision we're facing today would be an easier one if we had a large placebo-controlled data set. But here's the problem with collecting that data set for exon 51. We're already starting with an orphan disease. Then you remove the 87% of patients that aren't amenable to this exon skip. Out of the remaining 13%, you take away the 1/3 of boys who are too cognitively affected. Then you need to remove the boys who have already participated in an exon skipping trial and are no longer drug naive. Then you subtract the families that live too far from a study site to travel once per week. Then we lose the families that have chosen to participate in a less demanding clinical trial. Then you subtract the families that cannot afford clinical trial participation. For example, my own family has spent over $40,000 in childcare and lost wages to participate in 2 clinical trials. Lastly, you need to subtract the boys that do not fit the inclusion criteria. They're too old or too young. Their pulmonary or cardiac function isn't strong enough, or maybe it's something as simple as elevated white blood cell count during the screening. But they may not fit in the narrow 6-minute walk criteria that's necessary to show a treatment effect over a shorter period of time. The result is that you're left with so few boys that you end up relaxing the enrollment criteria in order to get the numbers. And once that happens, if you're using the 6-minute walk, you've introduced so much variability into your trial that you've changed science into randomization roulette. Some may say extend the duration of the trial, keep children on placebo for a longer period of time. But this trial includes muscle biopsies under general anesthesia. If you think that procedure is minor, you should know that my son has a permanent limp from his 2 muscle biopsies in his quadriceps. So once you introduce this kind of procedure, absolutely a more minor increase over minimal risk, you have to involve the prospect of direct benefit for every participant, a requirement that is not satisfied by participation in a placebo arm. So we all know that a large-scale, long-term, placebo-controlled trial would give us some of the answers we're looking for here today. But here's the deal. We can't have one. It's not numerically possible, and according to FDA's own guidelines on pediatric clinical trials, it is not ethical. So when we can't have the optimal data we want, but we still need to make a decision, what do? Do we abandon a promising treatment? Or do we become more interested in getting at the truth than focusing on methodological concerns? That is a question we're answering today, and it's a question that's going to be asked more and more often with genetic targeting of rare diseases. The world's leading experts are here today telling us that what they're seeing is unusual. Our boys are changing in front of our eyes. It can't be ignored, it can't be explained away, and it needs to be acknowledged today. Thank you.